Hello, I'm Jenny, and I'm going to be presenting a case involving a patient that I treated in the outpatient setting who was diagnosed with progressive supranuclear palsy. So back in January, for 8 weeks, I was with Jackie Goodman, Rehab Associates, so we had this patient there. So the purpose for my case is first to educate on this disease and its progression because it was something that I did not know much about. And also I wanted to highlight how I treated his function despite his medical diagnosis. And then lastly, wanted to discuss the patient education piece that was really important to him and his wife and the rest of his family due to the progression of his disease. So my patient was a 76-year-old male. Prior to coming to physical therapy, he did not need an assistive device to walk, so he was independent in his gait. He could walk pretty far distances, like through Walmart. He could walk in and out of his church, no problem. And he obviously was independent in all of his ADLs and IADLs, so he was able to bathe and dress, feed himself, things like that, no problems at all. The patient began to notice his functional change along with symptoms in October of 2016. He felt he was moving more slowly than normal. He had difficulties with standing up from his chair, prolonged walking. I felt his balance was getting worse. And another interesting thing is friends and spouse noticed he was rather quiet. So he'd become more quiet, developed hoarseness in his voice. So that was the main thing I think that they noticed, that his friends and family noticed. So he saw a PA at a neurology office in town, and he was started on Sydnor because at that time they had diagnosed him with Parkinson's. So another thing we did was the photo, which is the focus on therapeutic outcomes. I'm sure some of you are familiar with this. His score was a 41, which means he had 59% impairment. So the photo, what it does, it measures the physical functional status or ability of patients through patient self-reporting. So it's basically a outcome measure where the patient is asked questions based upon what they can do and cannot do, and it calculates a score. And another thing I got from the photo website actually was they say that the patient's self-report measures are the gold standard for measuring outcomes that determine the value of care from rehab services. So when I tested his strength, I noticed that he was weak bilaterally in his lower extremities. You can see those values there. For balance, one thing that they have at Rehab Associates, they do a multi-site balance screen, which involves a bunch of different little things that they kind of put into one. We tested his 5 times sit to stand. He did have to use his hands on the armrest to stand up. He was not able to stand up without the use of his hands. And it took him 37 seconds to stand up 5 times. So obviously this indicates a high risk for falls. And then the multi-site balance screen was something that one of the PTs put together that we used to look at his balance, and it had a lot of things very similar to the Berg balance scale. And his score was a 15, which indicated he was at a medium risk for falls. And then we also looked at some modified CTSIB on firm surface with eyes open and eyes closed. And when he closed his eyes, he had 1 loss of balance, not fall, but just kind of lost his balance in 15 seconds. So for his gait, when I watched him walk, we of course took some laps around the clinic. He was obviously slow in ambulating. He had minimal shuffling with his feet, but usually when he would lean more to the left when he walked and sometimes would drag his right foot, and whenever he got really tired, he would lean backwards more than lean forwards. And we also attempted a 6-minute walk test. We did this without an assistive device because he didn't need one prior to coming to physical therapy, but he had to terminate the test at 4 minutes, 30 seconds due to fatigue. So he got really off balance and we needed to sit down. So just sort of a summary of what we found so far. Obviously he had decreased strength in his legs. He demonstrated impaired balance. He had decreased muscular endurance because when we did the walk test, it was not anything cardiovascularly that made him stop. It was clearly fatigue. He had an altered gait pattern. And we noticed that his signs and symptoms were not consistent with Parkinson's. So at the end of our initial exam, the patient's wife actually asked us and said, she just kind of looked at us, and she was a former nurse, so she's familiar with these diseases, and said, "You don't think this is Parkinson's, do you?" And I was like, "I don't think it's Parkinson's." So we suggested that maybe she get a second opinion just because she wanted a more definitive diagnosis, and obviously having something a little more definitive, or at least trying, would help guide my research and guide what I was doing if there was something I could do that would help this function a little bit more than what we were doing already. So his plan consisted of physical therapy twice a week for 8 weeks initially, and it consisted of strength, balance, and gait training. And we were unsure of his outcome due to the progression of disease, or the potential progression of disease. So he did go to Roanoke to see a movement specialist, and at that time he was diagnosed with progressive supranuclear palsy. So here's our ICF model. The impairments you see are listed there. We talked about this already. His activities, the main things that he wanted to be able to do were walk long distances, especially going in and out of his church. That was important to him. Standing up from his chair, closing his recliner was important to him. He was having a hard time pushing his feet back to close his chair. He was a churchgoer. He lives in a 2-level home, but everything that he needs is on the main level, and it was a very open floor plan, which was good. And he had a walk-in shower. And of course, his personal factors, he's 76 years old, a husband, father, he had good family support, and he was very motivated. And he had, his wife was also very motivated. So his new medical diagnosis. So now I just would like to give you a little bit of information on this disease because it was really interesting to me. Clinical features of this disease are listed here: postural instability with recurrent falls, and usually the falls happen backwards, not forwards. That was something that was it's obviously different from Parkinson's. Vertical gaze palsy, pseudobulbar palsy with speech and swallowing problems, bradykinesia, axial rigidity, subcortical dementia, and then a clumsy gait, more like a drunken sailor. So not a fascinating gait, which is what you would see in Parkinson's. And then I'd also like to point out that subcortical dementia, that usually begins with problems with attention and motivation, emotionality, whereas your cortical dementia begins with more higher level issues like memory and language. Vertical gaze palsy, with that we're thinking of the up and down saccadic movements of your eyes. So things like stepping over obstacles, stairs, curves, judging distances, those kinds of things are what you're going to be looking for in that. So just where does this come from? An overproduction and accumulation of the tau proteins, and those cause the neurofibrillary tangles and then eventually neuron death. Those tangles block or distort the nerve impulses. And then of course, lots of affected areas in this disease that you see there. And I wanted to point out 2 more things. First of all, the most specific diagnostic feature that I saw in a couple of things that I read was that vertical gaze palsy. And it may eventually include horizontal eye movements as well. And the normal progression of this disease is 5 to 7 years. So from the time of diagnosis, usually a person will live about 5 to 7 years. All right, in 1995, the National Institute of Neurological Disorders and Stroke and the Society for Progressive Supranuclear Palsy established the most currently accepted criteria for the diagnosis of PSP, and then in 2003, these criteria were redefined. So here you see just different criteria for possible, probable, and then definitive PSP. And what was really interesting was you can have MRI to look at the brain to see if it's possible, but the only definitive way to diagnose the disease is at autopsy. I thought that was interesting. And then this is something else I found that was really interesting, just different stages of PSP and looking at when you have a patient that has this, trying to see, okay, whereabout are they in this disease? And when I saw my patient when he first came in, I would have put him about at an earlier mid-stage, just because he didn't have any advanced stage symptoms. He was still able to walk. We did eventually, and I'll get to that, have him use a rollator, but he was able to walk without an assisted device when he first started with us. Okay, so his initial plan of care to address muscle weakness, a lot of different exercises. And the main thing I wanted to highlight here with his exercise is one day he would come in and he would feel really, really, really good. And we'd be able to do lots of things, lots of sitting and standing and lots of stairs, stepping up and down. A lot of harder exercises for his strengthening. But some days he would come in, he had a hard time even walking in the clinic. And he couldn't stand up more than one time from a chair. And a lot of times that one time would take 30 seconds to stand up. So based on how he presented at each visit, I had to modify what we were doing. And just another little tidbit on that. I wanted to make sure I didn't load my patient with difficult exercises all the time when he was fatigued, because I was concerned about his state of mind, because this disease can obviously lead to depression because it's progressive. And so I wanted to make sure he felt like he had success when he came to PT, because obviously he could, with this progressive disease and with many, you can lose hope. So I would push him as hard as I could, but then I would also just kind of keep in mind that, if he's not doing well, or if I could see in his eyes, he didn't talk much. So if I could see in his eyes that he was becoming discouraged, we would change our course and do something different just to help him continue to have hope. So I obviously did a lot of research, did a lot of reading to try to find out more about this disease. This was a case report that was done to describe the effects of a long-term participation in an exercise program. And this particular patient had combined corticobasal degeneration and PSP. So it's a little bit of a different patient than the one I had. He was a male dentist and he participated in this exercise program for 10 years. So he did really well. And the results of this were that he demonstrated a reduced fall frequency and retained his community ambulation using a rolling walker. Let's see. Okay, so then for his balance, we did a lot of tandem stands. So we did some narrow basis support. We did firm surface. We eventually progressed to AirX pad, and he was able to do the firm surface really well. And what I'd really like to highlight was the balance intervention. In this balance intervention section was the eye movement training evidence that I found. So vision plays a critical role in gait because it provides input for various anticipatory reactions of the body in response to obstacles in the environment. So, and also the saccadic movements of the eyes occur normally in healthy individuals. So but these movements are hindered in a person with PSP, which could potentially lead to a fall. So if you're unable to have good eye movement, then you can have a fall. So that was really important to me. So a couple of different studies on the eye movement training. This one, the purpose of this study was to compare a rehab program with balance only to a program with eye movement and visual awareness training along with balance training. And there were 19 participants who had moderate case of PSP. And the results were that the treatment group had significant improvement in stance time and walking speed. And the treatment group was the group that had the balance training with the eye training. So that was really interesting to me, that they did really, really well. And the authors of this study speculated that outside of the basal ganglia, the brainstem and frontal cortex might be recruited by balance and eye training. So I thought that was really interesting. This article is actually really great. I read this one a few times and picked up new things every time I read it, I felt like. So this study was to determine if foot kinematics are impacted by gaze shifts. And the results were the subjects with the gaze shift deficits were more likely to have a trip or a fall because of the lower foot lag. So it was not as much the first step that was, or the first foot that was going up, but it was the lower foot. And then another intervention that I found in literature that I thought was interesting, which would have been really good for him, but we didn't have the equipment for it, was body weight supported treadmill training. So that would have been something that, having had the equipment, I would have definitely initiated for him. So for his gait, we did a lot of cueing, appropriate gait patterns. So good heel strike, good stride length, obviously good posture. Again, he likes to lean backwards, so trying to get him to not do that and stand up nice and tall. Obstacle courses, we did a lot of different obstacles, and some days the course would be really long, we'd have a lot of neat things in there, and then other days if he wasn't feeling as good, it would have to be a lot shorter. We did tandem walking, sidestepping, backwards walking, all with, usually with upper extremity support. Sometimes he could do it without, but usually he did because he wasn't too steady and walking in different directions. So falls are often associated with trauma and a lot of times mortality in this disease and in others. So lower extremity strengthening was performed in an effort to improve his lower extremity strength and coordination in his activities of choice, especially things like closing his recliner, walking, and standing from a seated position. So improvement in his gait, balance, and strength not only would help improve his function and keep his quality of life, it would also help him avoid a fall, which could be catastrophic for him. So we get to progress note time. I'm like, woo, how did we improve? Well, we did not. So, which is probably the hardest thing for me in this case was this part. But he did show a decline in strength a little bit, decline in balance, decline in walking tolerance, and a decline in function. So his photo score went down by a point. And here's just outline from initial evaluation to his 10th visit progress note. How some of his lower extremity strength decreased. And his 5 times sit to stand. In 53 seconds, he could only stand up 1 time. And his tandem stance times also went down a little bit. We did retest 6-minute walk test because it was the test we did before, so I kind of wanted to see how that compared. And he had to terminate the test at a minute 44 due to fatigue. Another thing I initiated at this time, and I wish now I would have researched and found this scale and done something like this earlier along in our case here, but was the PSP rating scale. This was developed by Lawrence Gold to assess the level of disability in people with PSP. The Unified Parkinson's Disease Rating Scale can also be used for PSP, and the motor section of this scale has been shown to yield valid and reliable data for patients with PSP. So, what now? I educated the patient on the use of a rollator. So he brought a rollator in and we practiced with him in the clinic. We made sure it was the right height. We talked about how to take rest if he was walking long distances. We worked on his posture again, taught him how to obviously lock the brakes before he turns around and sits, things like that. And we spent quite a bit of time doing that. I also created various home exercise programs for him, depending on, that day if he was feeling really good. We had a program that was a lot of higher level exercises that he could do at home, and then some that he could just do if he couldn't make it out of the bed that day, because there were days that he couldn't get out of bed. So, and a big piece was educating the patient's spouse in accommodating to the needs of this disease. So I gave them some information, and a lot of times in PT we talk about, don't do that, don't give the patient any information, because we don't want to scare them. In this case, we knew that he was going to progressively get worse. That was the nature of this disease. It's progressive disease. And so, especially for his wife, I thought it was important for her to kind of know what to expect and what to look for. So we did give him some information on it, and she was very, very grateful for that. When I finished my internship there, he had a few more visits left before his discharge. And one thing I would have considered, had I been the one to discharge him, I definitely would have considered a home health recommendation, including PT and possibly speech therapy to help with the speech and swallowing to help preserve that quality of life. Because that was something, again, it was going to get worse, but I think the important part was helping to just preserve what he had for as long as possible. Okay, so here's my patient and his wife, and then Jackie and I. So what my patient taught me, he taught me a lot. He was really sweet, we had a great time together. But first, as we have all been taught, treat the impairment and make the goal of therapy to help improve or in some cases maintain their function. So the medical diagnosis, it definitely can help guide your research, and that's what it did for me. I would not have guessed that for PSP we should do eye movement training, and we did. I did a lot of saccadic exercises with him. I made him a big long list of things they could do at home, some YouTube things. I made him the sticks with the basketball and the soccer ball so he could work on that. I gave those to him. So I would not have known that had I not gone back and found that evidence. So the diagnosis in this case, even though it was important for me just to treat his function, what we did, walking, stepping up, sitting and standing, things like that, even hamstring curls so he could close his recliner. We did a lot of those types of things, but you're treating the functional loss more than anything. Use the diagnosis to help you with the research and the evidence, but make sure you're treating their function. And then sometimes with a progressive neurological disease, the patient will need a maintenance program to help him or her maintain their function. And so that's what I did. I wanted to try to give them things that they could do that would help maintain that level of function. And if you don't know the answer or you're unsure of how to help somebody, find the answer, because in a lot of cases, you're the patient's only advocate. And I'm sure all of us have seen that in our what are they called? Internships so far. So just be that advocate, because you might be the only person that actually tries to find the answers for that person. So make sure we're doing that. Are there any questions? Should have asked that a long time ago, but yes.
I was wondering if the multi-site balance test that RACB uses looks at different kinds of balance. Like, does it differentiate between anticipatory balance or reactive balance, so that you kind of knew which kind of balance maybe he was more impaired with?
So this balance screen, I think it was, I have it actually up here, but it was basically like half of the Berg, or the Berg condensed is what it was. So that's basically what it was. And looking back, I kind of wish I would have just said, no, I really just want to do the Berg. I think I would have rather done that so that it was a more reliable tool to use to have outcomes. So I think that's one thing I definitely would have done differently, is to use that. But that's basically what it was a condensed version of the Berg.
when you did the reading eval and you saw like a decrease in function, do you attribute that more to like fatigue during the visit or just the progression of the disease?
So I've actually been keeping in touch with him since I left, and he is already confined to a hospital bed, and they've called hospice in already. So one other thing to add, thank you for asking that because I forgot to say this, but a lot of times with this disease, the initial symptoms are not even really noticed, and especially for someone like him, maybe the age of 72 or 73, he was noticing his balance was bad, or he was, not able to walk as far, but he was probably just like, hey, I'm getting old, because a lot of times, not only is it misdiagnosed the first time around, but it also, a lot of times those symptoms just aren't picked up as being this disease. So I, of course, am like the glass half full kind of person. So I'm like, well, Jackie, maybe it's just a really bad day, but now I know it's been a pretty quick progression of the disease. Now I know that because of where he is now.
My question was just when you did the retest, did you feel like it was a bad day versus progression? Did you have a sense of that at that point?
It looked very similar to just a bad day. That's what I thought it was.
Because I mean, you had been hopeful to get, it sounded like get better measurements and you didn't. So
Right. So
that had been like
and he had more good days than bad days usually at the beginning. And then towards the end, it was like those bad days were becoming more frequent. So we'd have like 2 good days, then a bad day, and then a good day, then a bad day, and then 2 good days. But then towards the end, it was more like good day, bad day, good day. So it seemed that those bad days, and also from patient reporting. So they would come in and say, he wasn't able to get out of the bed yesterday. And so those sort of subjective things that they would tell us were also that it was just progressing.
It seems like you did a really, really good just review of the disease and found a lot of great research. I'm interested in the article, especially you did the exercise program for 10 years, right?
Yeah.
And the kind of projected prognosis is 5 to 7 years.
Yeah.
So in all your other research, did they ever talk about like physical activity or exercise improving prognosis or anything like that?
One of the articles that I did read said that there's a lot of limited research on it, and again, that patient was a little bit different. It wasn't just the PSP patient, so there's a little limitation in that study. But there is a lot of smoking evidence out there saying that it helps, and there's also no medical medicine that you can take really that helps it either.
Okay. And that was actually I was going to follow up. Was he still on the Cinemed or was
No, thank you.
there any medication that could help with that?
Yeah, about halfway through, his wife, I guess it must have been before he ever went to Roanoke, his wife said that, she's like, he's taking the cinnamon, but I just don't think it's helping, and she said, they told us to give it time, but I just really don't feel like it's helping, and if this is in Parkinson's, then I don't want him to take the medication. So once he got that diagnosis, he came on medication.
I was just gonna ask, what was the time lapse between the misdiagnosis and then when he was actually diagnosed with palsy?
He went in, I believe it was October, November that he went in Lynchburg. No, it was December. It was December, so it was basically a month later that he went to Roanoke and got the diagnosis.
Were you done?
Yeah.
Okay, so I've got a list.
Come on, lady.
Some of them are like just the same things other people have come up with, but looking at the study that Trevor was talking about with the case study, did they tell you there what was the intensity and frequency and the types of exercises that they did?
Let's see.
Like, was it the same kind of stuff that you were doing? Was it like generalized functional training, balance training?
It was.
Kind of a circuit training sort of thing?
It was a lot of the same things. And I have just a little blurb here. I've got the article with me, but I have a little blurb here. He did 20 minutes of trunk and lower extremity stretching and strength, 10 minutes of upright balance and strength, and then 20 minutes of treadmill walking. They did 10 minutes of forward, 10 minutes backward. Now, I was nervous to put him on the treadmill because we had a treadmill, but it wasn't one with bodyweight support, and I was just nervous to put him on it because he didn't seem to be steady enough for me to spot him on there because it kind of sat up high. So, but that's what they did, and I know that I can find it in here.
So we have a graduate who has a patient with PSP, and she was like asking for anything, I don't know if she speaks now, but, and then did his bad days follow anything definable? So like, was it a day after hard work, was it weather, was it that he had a UTI going on or a little cold or
It was
nothing.
just, yeah, because I would make sure to ask that, like, well, what did you do yesterday? Nothing. Oh, okay. So yeah, it definitely didn't follow any sort of rhyme or reason or any pattern at all.
Is that pretty common from what you read about the disease? 'Cause I really don't know anything about this disease, so I've never seen anybody with it, but like, was it something is that the pattern, good day, bad day for this? Is that
I didn't see anything, I didn't read any research on that, but I would imagine that it could be that way.
And then, last one, was there anything kind of like patients with ALS? We hit them up earlier in the progression to like for advanced directives, end of life kind of concerns, like knowing that they're gonna go down, like let them make plans then while they're still have their cognitive faculties and stuff to say,
Right. I think that definitely would be something that they can do. And I think for this particular patient, I think it just caught them so off guard. It was just so quick and
So
so fast that it was
fast,
just like they were kind of blown away by it. And he was fortunate too that his wife used to be a nurse, so she was really just know kind of what was going on and know what to expect and knew how to set things in place. But I think you definitely can. And one of the eye movement training articles actually talked about some more of like the really geeky stuff about how the eye movement training helps with that. So I'm not sure if just doing it earlier on and like you're saying, like hitting it hard, I'm sure it has to help, but being that it has to do with those tangles developing in the brain, you can't really slow that either. So, the main thing is just trying to keep their function.
oh, I had another one.
Hey Jenny, nice job.
Thank you.
Well, Dr. Lady's thinking about stuff.
Yeah.
So just want to ask
My
a question
table.
around the plan of care. When you hit that, hey, we're gonna see how long you did after these 30 days or whatever it was, and you ended up saying you didn't. How was that discussion with the family and
It was
patient?
really tough.
So how did you adjust the plan of care in around that? Talk about that.
Well, again, I'm definitely glass half full. So I try to just, I guess, make that whole discussion as positive as possible. Like, yeah, I'm gonna get the role later, like, woo! Yeah. Because I was just sad, but it was definitely hard to discuss it with them. But I think that she had already done a little bit of reading for herself. So it wasn't like I was telling her too many things. A bunch of things that she didn't already know, but at least she sort of had a warning, like, okay, I know kind of what's coming. But we kept doing, I think, the thing that I did the most towards the end was more of the eye stuff, because I just found such really good evidence for that I was like, all right, they need training on that. So the last few sessions, we toned down more of the exercise. We still did some of his exercise and modified based on how he presented, but I spent a lot of time trying to teach him how to do those eye things because that took cognition on his part as well. So I took more time trying to train that, and I taught them, they brought the iPad in, I taught them the YouTube things, and I had to practice them a lot to make sure he could do them. So I geared it more towards that because I knew that was something that I could explain and train him how to do, because most of the exercises he'd been doing and could continue those at home.
Was there concern around the payer source on that, or was it, okay,
I'm
nothing
sure-
again, we're going to cut you off?
I'm sure that there is, and I think that was, when Jackie and I talked about that was sort of a concern, because if they're not showing the improvement, then it's hard to justify paying for PT, which is another tough thing that I don't like, especially for this kind of thing.
I remember if they were, but I can hit you up afterwards.
Okay.
One that's really interesting